what's happened in the last 60 years, or even 50 years, because arthroscopy and such was not even that relevant until the 70s, okay? So, let's start with just looking at our conditions. We know what a normal joint looks like. You know what an osteoarthritic joint looks like, and you may well be able to tell the difference between the two with rheumatoid arthritis as well. But the main thing is you know what the pathologies are. You can identify the pathologies. You know the reasons for it, and you understand some of the complications. Now for RA, we've already talked about it. Systemic, right? And it's the inflammation of the synovium, those Panus cells, etc. It's symmetrical, and that's a tragedy of it. If you have it in your left and you're going to have it in your right. And why? It's just an amazing situation. Also, as we know, it's an autoimmune disease. And because of that, it's been very difficult to understand what triggers the autoimmune response. But these DMARDs are certainly important in dealing with them. So we know what OA is. The vast majority of people on the operating table are with osteoarthritis, right? And both of them are because of the erosion of the articular cartilage and the density of the subchondral bone. And so we know the risk factors as well, right? We know what helps to cause it, age, trauma, and sometimes activities, etc. So there's no disease-modifying drug. If you're losing your articular cartilage, you can't put your articular cartilage back, okay? So what are the symptoms? Pain, joint stiffness, swelling, crepitus, Rice Krispies, crack, snap at the top, and the osteophyte formation. So we know that the bone's reacting to the degeneration. And so we're not going to go over much of this. I think you've all been well aware in understanding the anatomy, which includes, of course, not only the bony structures, but the musculatures, as well as our tendons and ligaments, right? Very important stabilizing structures. The ligaments are these stabilizing structures of the knee, not just the medial collateral, but also the ACL and the PCL. And if we cut them out, then in the implant world, we've got to figure out how to do it. Varus and valgus. Normal, varus, the degeneration of the medial compartment and collapse pushes the leg out, pushes the ankles in, and is by far and away the most common part of osteoarthritis that patients have. Valgus is not nearly as common, and that's bow-leggedness, and your ankles are going further out. Mechanical, every one of you talked about the mechanical axis, right? So you certainly know how important that is. And when we're balanced, then the mechanical axis helps to keep us more in line with the midline, so that the load's being distributed evenly compared to a valgus or varus or a valgus. No, that would be a valgus. Okay, some of you talked about the Q angle as well, that the tracking of the patella is quite important, and that's really all you need to know. Don't worry about the degrees, just what the Q angle does, and that's how keep the patella aligned. And we know this, right? The 6 degrees of motion, very important. It's not a simple hinge. It's a very complicated knee. The knee is very complicated. And early on, when they were looking at hinge knees and trying to make them work, they were really running up against a wall because of all these motions. And what do patients want? They want function. They want pain relief, and they want function. And do the things that they were doing the things that they wanted, that the reason they were having the surgery. In order for them to do that, the biomechanics of the implants need to respond to these forces. So, I think we understand some of the basic biomechanics of the knee and such. The metals that we use are the stainless steel, cobalt chromium, titanium alloy, as far as the metals. And then we have our ultra high molecular weight polyethylene. That's still ultra high molecular weight polyethylene. That hasn't changed. What has changed is the processes they use to slightly modify the characteristics of the polyethylene. And that's cross-linking and using vitamin E or both. And of course, we understand the surfaces of the implants now. We have smooth surfaces for cement, but we have roughened surfaces like porous coatings or arc deposited plasma spray for bony ingrowth, for biologic stabilization of the implants. And now we've got these more advanced surfaces that have much greater porosity, much rougher, and they have connected pores that the bone can literally weave it in and out of the implant. So, what does our total knee look like? You know what it does. It's a femoral component with a tibial insert. Patella, for the vast majority of cases in the United States, we resurface the patella. We resect part of the surface and replace it with plastic, and then we implant a patellar tray, or a tibial tray in the tibia, and that's our final result. And we know what kind they are. The vast majority of them are cruciate retaining or posterior stabilizing in the United States, but these new cruciate sacrificing deep dished implants with the medial pivot are becoming more and more popular with manufacturers. And we also have another style, and that's the rotating platform. It doesn't have the market share that a number of the other implant systems do. It's really being pushed by Pew more than any other company. A number of other companies have it, but we know about the rotating platform, and that's to let the insert rotate to wherever the femur wants to go. And so we talked about femoral rollback, right? We can't get flexion unless the femur rolls back in some fashion. And with the posterior stabilized insert, they use the cam and post. Others might use the deep dish to force it back. And with the cruciate retaining, of course, we know what pulls it back. You have the PCL, right? So femoral rollback in the two major systems is either the cam or the roll bar and post, or the PCL and the cruciate retaining. That's what gives us the component to roll back the posterior aspect of the tibia. And we have these condylar knees as well. They're not as popular in the United States, probably about 6% of the market, but it's growing. And the reason it's growing is some of these young people some of these younger patients coming in that just have medial compartment disease, and there's no reason of hacking out all this other great tissue. And if you can give them 10, 15 years with this, and then you can put in a total knee, that's a better scenario. So I think we're going to be seeing more of this because of this. All four ligaments are intact, right? The collaterals and the cruciate ligaments are intact with the unicompartmental. But don't forget that we still have modularity in the knee. These are the revision knees with the posts and the wedges and the stabilization of the implant with certain mechanisms like posts and rotating hinges. So don't forget about when you see this, that, you know, these are very sophisticated systems now that you can literally build it to whatever bone loss, ligamental loss, and motion that you need. What are the problems with total knees? I don't think we have to go through this too long, right? Infection, we know about that. It's a comorbidity, very, very challenging because of the fact that most of these have to go into two-stage, and it's very dramatic for the patient and the surgeon. Polywear, we've understood that for a long time as well. And what happened? Flat surfaces, backside wear, implant mating geometry that didn't fit together real well. And what was the result? Particle osteolysis. And osteolysis is a big deal, still is a big deal, because we've got still a lot of implants out there that could be having some trouble. And aseptic loosening, ingrowth failure, malalignment, whatever, and instability, ligamental balance. That's what we're talking about a lot now. It's the way soft tissues around the joint are tensioned correctly and balanced, and making sure that the tibial rotation and the patellofemoral tracking is correctly aligned. And of course, we've had design issues with the press fit, the pegs and the beads and materials. And so now let's look at the hip. I think you know the anatomy of the hip quite well, and what the anatomy is that we impact. The biomechanics of the hip and the biomechanics of the knee are completely different. And so, but they're the same thing. The biomechanics of the knee and biomechanics of the hip are completely different, but at the same time, the implant systems they're using have to replicate those biomechanics. That's what I was trying to say. So we talked about the offset, we talked about the pivot point of the head, the center of the head. This is our target for the hip. We want to make sure the implant hits this target, okay? And we have to watch our offset so we have the right tensioning of the joint. The neck angle we've learned is important because it impacts the offset. And when we look at the offset, the neck angle, we can see it. And we know what the definition of the offset is from the center of the head to the anatomic axis horizontally. Okay, and our neck angles, varus, valgus, and normal. If the test says 120, 135, or 125 to 135, that's the correct answer for normal, okay? I don't want to throw you off with my opinion, but this is what my orthopedic surgeon friends say is it's 125 and 135. They got somebody at 120, that's a varus. That's a varus neck. But anyway, you know what I'm talking about. And then the modern arthroplasty. What did it do? It combined a femoral component that replaced the neck and the head, and then he found a plastic cup that could articulate with his metal component, and then stabilize both implants with bone cement. So that was a breakthrough. Not only did it affect hips, it affected knees, it affected shoulders, and probably some other areas of orthopedics that I don't even know that they're using bone cement, like maybe maxillofacial and other things. So we know what the components are. The modern one is a metal hemispherical shell with a type of ingrowth surface with a liner. It's plastic. Very few other options. We talked about it. The ball, either ceramic or metal, and the hip stem that is replacing the neck and the head of the femur and is stabilized in the metaphysis and the medullary canal. Okay? We know what the stem designs are. They're cemented or they're press fit. But unlike the knees, we sure have a lot of different styles and designs, don't we? We got different tapers, we've got short stems, we've got curved stems, we've got proximally loading stems, we've got distal loading stems, and modular stems. So it's quite a group. And again, we've got these new materials that we're using in the hip, much like we are in the knee. And so I think you understand everything from the trabecular metal to titanium with striker, biofoam, friction, etc. So what can your cup do? Well, it used to be in the 90s and the early 2000s, there was a race between metal liners and ceramic and polyethylene and the new techniques for enhancing polyethylene. But the winner is cross-linked polyethylene, right? Because we've had issues with metal on metal and ceramic on ceramic, but ceramic heads are still very, very popular. So it was challenged, and the winner is, even though ceramics had such a great potential. Both hard surfaces didn't work, but the polyethylene head on the ceramic head on polyethylene is working quite well. Okay, so what happens to pull these patients back to the operating room, having the primary total joint fail? Well, the same causes as knees, right? Infection, polywear, and you know, recognize this. You can see that when you see these big cavities around the implant, when you see this femoral head move severely, you know that you've lost all that polyethylene there. So that's the reason for the osteolysis. So thin poly or positioning of the cup, a number of reasons why poly can wear, and the end result in many cases can be osteolysis. And as you know, that's the big O, that's the monster. Mechanical loosening, we see it in the knees, but we probably see it as much in the hips. That if we don't fit these implants well, both the acetabulum and the femur, then it's difficult for the bone to grow into a moving target. And if you don't get bony ingrowth, but you get scar instead, or you've got such a thin amount of bone on certain parts of the implant, they're going to loosen. And a lot of it was because it wasn't a good surface for the bone to grow into. This implant's supposed to be up here. It's sunken into the femur. So the initial bony ingrowth surfaces weren't the best, weren't as reliable. Manufacturing issues early on, interface debris that stimulated some problems in design to get these things in tight, and it caused biologic reaction. And of course, in the hip, what we have, which is unique, like the shoulder, is dislocation, and that's a big, big deal. Obviously, if you've just gone through a surgery and you've had implants done, then you don't want to see this, because you'd hate to have to go and revise an implant because it's not stable. And why? Malposition and laxity is probably the big deal. The other reason is leg length discrepancy. It's too tight or too loose, too short or long, and it dramatically impacts the gait, the function, and frankly, can generate pain as well. So patients don't like that in the hip. And metallosis, we talked about that already. The metal on metal articulations with metal. It developed some wear debris, stimulated tissue reactions, and metallosis is a coin name for metal debris that stimulated soft tissue reactions. And just like in the knee, even though modular necks aren't popular with hips anymore, and some of the modular cones on the stems, it certainly is in the implants that are revision implants. Just like the knees, the ability to be able to build different heights and dimensions of your proximal body and uniting it with a distal implant that can be secured in the diaphysis, having a lot of options for bone loss in the acetabular, very, very important. So revision implants, it's a whole different world than the primary implants. So now let's look at the shoulder. Complex, we've already talked about it not too long ago. It has a lot of similarities to the hip, and it's a ball and socket joint. And then, as you know, the stability of the hip is much greater than the inherent stability of the shoulder. So what do we need? We need these static stabilizers. That's the capsule, the glenohumeral ligaments, okay, and the dynamic stabilizers of the muscles. So by having your shoulder here, you're being stabilized by your ligaments, your glenohumeral ligaments that form your capsule. If you're stabilizing your arm out here, it's musculature, right? But both of them are very important to stabilize the limb. In our anatomy, I think you understand the AC ligament, the clavicular, coacoclavicular, and coacocacromial ligaments, the labrum, the tendon of the biceps, and the joint capsule in the labrum, the ports of the labrum, making the glenoid 50% deeper. The anteversion, retroversions, right? The humeral head. But generally, our retroversion is about 30 degrees. That's kind of where Dr. Hawkins and everybody else seem to want to put it. It might be a situation in the future that they're going to be able to dial in individuals' retroversion much better. Okay, so retroversion of 30 degrees, anteversion, a range for the glenoid, but not a lot. That's not a lot of differentiation compared to this. And of course, the neck angle of the humerus is what? 135? Yeah, okay. So you got to know this, right? The rotator cuff is just absolutely essential for normal functioning of a shoulder. And when it gets damaged or torn, it is very impactful for the shoulder. All those other muscles, the deltoid, pectoralis, all the trapezium, and all the others that influence the scapula and the shoulder are of course very important. But when you start to lose your external, internal, some of your abduction and adduction because of your rotator cuff, it's very impactful. And we know that the deltoid is the big boy. It's the biggest muscle in. And when we're going to a reverse shoulder, we rely on the deltoid a lot, don't we? Okay? So, shoulder, most dislocated joint. I don't think anybody doesn't remember that. But shoulder dislocations are quite common, and it's because of the huge amount of motion. The greatest amount of motion in the joint in the body is the shoulder, and because of that, and because of the very shallow nature of the glenoid, it can obviously dislocate. It's the number one joint dislocation in the world. Shoulder separation, the tearing of the AC ligament, and the destabilization, or can be the destabilization of the acromion and the clavicle. And of course, much like the hip, the big issue is the degeneration of the joint. The need for shoulder replacement is because of arthritic damage. And the big impacting area is osteoarthritis.
Sorry, DC, I'm late for an appointment.
Okay.
So just about. You back next week? I'll fix it.
So you gotta know this, right? And what's the definition of arthropathy? Degeneration and tearing of the rotator cuff that's unrepairable because of the degeneration of the tissue. And so arthropathy is a big deal. It's really restricted mainly to older individuals. And when it happens, it's very impactful to their function. So we know that arthropathy leads to a certain implant system that we're going to be talking about now. So what are those systems? We have resurfacing, we have hemiarthroplasty, we have the total shoulder, and we have the reverse shoulder, right? And when you have arthropathy, more than likely you're heading this way because you have very little stability in the joint. So, resurfacing and hemiarthroplasty. Resurfacing is just resurfacing the humeral head. Hemiarthroplasty is removing the humeral head and stabilizing the humeral proximal humeral metaphysis and diaphysis, but not resurfacing the glenoid, articulating against whatever's left of the articular cartilage of the glenoid. The total shoulder is replacing the humeral head, stabilizing the stem down into the metaphysis and the canal, and replacing the glenoid, resurfacing the glenoid. Of course, we know about the reverse shoulder. It's just that the large glenosphere is anchored into the glenoid, and this deep cut, much deeper than a standard glenoid component on the humerus, gives it much greater stability. But let's not forget about the stemless designs, right? And the stemless designs are used in total shoulders. So you can replace, you can use this for a hemi, but the vast majority of the time, if you're using a stemless, you're probably doing a total shoulder. So you're replacing the glenoid as well as replacing the head of the humerus, but not relying on the proximal, or not relying on some of the metaphysis and the diaphysis of the humerus to stable the implant. These are becoming quite popular, right? The stemless ones. And of course, in unlike hips and unlike knees, modularity is important in shoulder.
DC, could you remind us again what those implants are called for the stemless? The cage one is
This one's Simplicity from Wright Medical, and this one is, which one? This is from Arthrex.
The Eclipse.
Yeah, the Eclipse. That's right. Right.
Are there a lot of implants on the, like from the bottom of the station?
Not too many. Not too many, but generally the more popular ones, I think. Okay, so modularity, unlike the hip, is important because it's a non-weight bearing joint. So they're not worried about a lot of wear debris being generated, metal wear debris being generated. And that's why you got some pretty crazy designs like the Universe from Arthrex that has a modular or an adjustable proximal body that has a mechanism inside of it. And we know that, like our biomechanics in the hip and the knee, that the height of the head, the offset of the head, and the thickness to replace the appropriate amount of thickness of the humeral head is important to tension the joint correctly. And this is our reverse shoulder. What does it need? Arthroplasty. In some cases, it's a salvage procedure as a revision, but most of the cases, still, it's for arthropathy. The patients have lost their soft tissue balance. So we look at trauma. We've got cables that are great around periprosthetic fractures and circumferentially compressing a fractured bone, particularly in the diaphysis, very, very important. And we still have our pins that were developed 100 years ago, like the Kushner pins or wires that you can use a wire passer or a pin driver and put the Kushner pins to stabilize fractures while you're putting your other implants on, etc. But obviously, the orthopedic screw is very important. Knowing the threads and the differences in the thread pitch is important because it impacts the way the screw is used. A 6.5 millimeter, a 6.5 40 millimeter screw is the major diameter of the threads and the length of the screw. Of course, we know about cancellous and cortical.
Are those thread types or screw types? On the test there is the thread type, and I put fully versus partially, but I know a lot of people
Yeah,
cancellous versus
on that
cortical.
question, the key was hard and soft bone.
Okay.
They didn't say
So-
cortical because the answer was cortical and cancellous.
Yeah.
The
Oh.
hard bone is cortical screws. Cancellous soft bone is cancellous screws.
That's. Ugh. Did we get that one back because it's a thread type?
Well, the thread type is different in cancellous and
Yes.
soft bone versus hard bone.
It's larger, but I don't know. That
Anyway, thread lengths, obviously we have, like
Yeah,
Sarah was saying, partially, fully threaded. This obviously is incredibly important. A leg technique using threads in the distal portion of the cortex across the fracture site that can compress it. It's a fully threaded screw. You use a gliding hole, or if you have a partially threaded screw, you don't need the gliding hole. And so this is a classic example of the threads passing the fracture, and as it advances into the bone on the other side of the fracture, when the head contacts and it's still moving linearly, then you know that it's compressing the fracture and stabilizing the fracture. Okay? But what is the definition of a screw? Can anybody tell me? Okay, Don?
Mechanical defined as a device that transmits a rotational force to a lateral movement.
Yeah. And can provide compression. So what are materials used in trauma? Stainless steel, titanium. They both have some very significant advantages. And one of them is the flexibility of titanium, like in titanium intermedullary nails, and the fact that it doesn't have nickel. Stainless steel is easy to manufacture, much less expensive, and is still very, very popular today. So we know what the AO principles are. I mean, I don't know if we have to, but it's what influenced the world of trauma. And even though they seem to be pretty simple principles, sometimes implementing these principles isn't so easy. So AO, right? Big group. And our plate types, we've got all kinds. We've got the basic, straight or angled or wide stainless steel plates that have compression ability, or we've got all these new fracture specific or anatomic specific plates. So we know what non-locking plates are. They just simply pull pull the plate down to the surface and secure it tightly against the surface of the bone, and the screws are bicortical. But now, non-locking plates, of course, now have the ability to have compression, right? Dynamic compression plate or the low contact dynamic compression plate. And all you have to do is remember Sarah and the Glide.
Yes.
Might not be the best memory, but I think you'll understand what the
Take the
dynamic
bottle back.
compression plate system is. And so that you can angle the screws as well in those plates. And the next evolution that's on the market still is the low contact or limit contact compression plate, so you don't have to, you have more vascularity available because of the tight fit against the cortices and the periosteum. And then, of course, the newest evolution is the locking plate, the LCP, locking compression plate. So the DCP, the LCDCP, and the locking plate all have that compression ability. What's important about the locking plate is that it's one fixed mechanical device, right? And so the screw heads and the plate are one. And so therefore, you have this stability and then the nearest cortex for stability. So you can use unicortical screws, whereas in the other plates you have to use bicortical screws. You can still use bicortical screws in a locking plate, but if you can, you want the plate to hover over, and so you can use both. You don't have to cinch down the plate with your bicortical screws, so you've got some options. And it's stability under load. You know, the standard plates, but the locking plates are so much stronger, and we've seen it. And of course, we talked about different types of plates, the neutralization plate, compression plates we already talked about, buttress plates for supporting the articular surface, very, very common. It is the plate of choice for the tibial plateau fractures, and a buttress plate concept is used in ankle fractures and distal femoral fractures as well. But this is the classic buttress plate there. And then we have bridging plates, right? Keep this fragment aligned with this fragment, the proximal and the distal and proximal fragments. And then everything in between is a bit of a mess that you try to pull together and let the biology, that is not absolute stability, it's relative stability. So primary fracture healing is biologic, and that would be primary because you don't have absolute stability for direct osteosynthesis or direct bone healing. This would be direct bone healing. From what I see, this would be relative stability in primary bone healing. So that's the biologic. They call it relative. They call it biologic osteosynthesis. Other people call it primary bone healing. Then we, as you know, we have all of our fracture-specific or anatomic-specific systems now for the elbow, the ankle, the distal radius, the volar plating, etc. And so we know about that. What else is important, particularly for diaphyseal fractures in the long bones, is the nail. It's just a remarkable device because it's very tissue sparing. It doesn't interfere with the biology around the fracture, and it maintains perfect alignment. And again, unless they've got very strong absolute, they're going to have callus formation, and they're going to have a primary bone healing as well. And so nails are very important. We've seen them and for a lot of long bone fractures, they are the internal fixation of choice. Then we have external fixators for all kinds of deformities and fractures that, particularly for soft tissues, right? Because you can't just be throwing in, you have this big mess for a leg, and putting a nail in isn't going to do any good because you've got such a comminuted mess and you've got big skin damage, etc. So for complex situations as well as for soft tissue injuries that you can't stand surgical intervention, external fixation. And it can get pretty complex, can it? And one of the great parts of external fixation is temporary external fixation. Having a major fracture like a femoral fracture, getting them out to length, that ligamental taxis, when you put that frame on, helps like a sailing ship pull those fragments back together and stabilizes, brings your vessels and nerves out to the right length. And then you can figure out what the definitive surgery is. And it can be done in 2 weeks, 10 days. There's no rush. And of course, this is the sophisticated tabular spatial frame. And then we got special devices too for our fractured hip. Because a fractured hip can present itself in many ways. And for an undisplaced basic subcapital femoral neck fracture, it is cannulated titanium leg screws. If it's displaced, cut it out, put in a bipolar stem, and have the bipolar articulate against the acetabulum that has still healthy cartilage. If it's intertroch fracture, it's the compression screw, hip compression screw that you used, or the trochanteric nail, right? So let's look at some of these x-rays and then I'll let you go. We've got osteolysis here, right? So there's no doubt that wear, when you see polyethylene wear, both in the hip, the knee, not so much in the shoulder unless it's loose, but that's a great concern. And you can see a loose component. It's supposed to be up here. Now it's a submarine. So for us to understand what we're looking at, you know what the difference is between a normal shoulder and a diseased shoulder. Smooth articulating surface on the humeral head, no osteophytes, good amount of articular cartilage from this base to this area here, no reactive bone. And of course, it's just the opposite with disease. Osteophytes, no joint space, no articular cartilage, reactive bone, and damaged surface. It's flattening the head of the humerus. Old style implant that fit distally, but used a metal back component. Those metal back components thinned out the poly. Some of them didn't have very good bony ingrowth. And as we know, the major reason for revising shoulders is the glenoid. So now there's a whole variety of press-fit glenoid or humeral stems. And this is a press-fit humeral stem in the hemming. There's no glenoid there. That's what it looks like before you put it in. And here's a cemented one. You can see the cement around the stem. You can see it distally here. You can see the little plug there with the little BB. You can see the 3 BBs there and more of a flat surface and a space, and you know that that's a glenoid component. Okay, now these Stemless devices, obviously that's stemless, and it is a total, because you see the space there, that's polyethylene, and you can see the cement and the spacing wire. The X-ray wire, that's embedded in the poly. And of course, that's a reverse. This is a cemented reverse. And is it in a good position? I can't tell you, but it's still articulating. And then you've got another style of press fit stem that tries to get fit here and distally, along with a glenoid component. So we go to the hip, same thing on the hip. Surface, joint space, no reactive bone, no osteophytes, compared to osteophytes, amazing reactive bone, no joint space and damage to the surface. Okay, so we got a press fit proximal loading stem, has some distal fit as well, and the basic acetabular component compared to a metal-on-metal resurfacing. And you don't see any wear here because it doesn't look like the head is moved medially or superiorly, and the bone around the acetabulum looks good. Bad deal here, press fit stem, it's dislocated. An older style stem that had some ingrowth. You won't see this but you'll see this. See the cement around it? And then here's a better view. You see the cement and the plug distally. And press fit stems. 90% of the market are press fit stems, right? The vast majority are proximal loading. 95% of them are proximal loading stems. This is a standard stem here from Smith & Nephew. You can see how much of proximal loading it is. And the stem fits the diaphysis well, but this is a loading proximal stem. That's the Karai. You can see how tapered it is. They don't want any fit distally. All the fits up there with their ribs and their HA coating. Knees are the same way. I think you can identify a diseased knee. I hope you can identify a healthy knee. And this is a loose implant. Those black lines aren't bone. As you know, that's scar. And this is a cruciate retaining knee, right? It has the post just like in our lab. The posts on that would be on a cruciate retaining knee. And of course, a posterior stabilized has the box, the roll bar, and the post. The best way to tell it is, of course, from the lateral view. No box here, just these posts. Box here, no posts. And this is just another type of stem that has some fracture to it. Unicompartmental, cemented. You can see the cement on the tray. Total knee, cemented as well. You certainly can see the cement distally and a little plastic component to it. And malaligned implant that's unstable that went to a revision implant. I think you can see the difference between this and this revision implant. And looking at some plating, we've looked at the modern plating. Certainly plates and screws are very popular. Example of a serious distal tibia and ankle fracture, and another using some of these more modern plates. And X-Fix, great example of using X-Fix here to align this crushed proximal tibia and eventually getting it to heal in some kind of alignment. And standard neutralization plate. You got your leg compression screw, inner frag screw there, and a plate protecting your interfrag, alignment. And this is classic, light screw, right? And again, direct bone healing, when you've got bone and bone under compression that are interfacing, and then primary bone healing when you don't have all of the two main fragments being able to be in apposition under compression, but you don't have that type of situation here. Distal radius fracture, and your IN nail, hip screws, bipolar. Okay, sagittal view of an MRI, right? The side view. Coronal view, coming in from the front. And then finally, an axial view, coming down from the top. Okay.
I have a question. It was on the test. It was an extra-articular, non-displaced, distal radius fracture.
Right.
Would that be used with the volar joint or with the cast?
Cast.
Gotcha.
Non